Good evening, ladies and gentlemen. I am Dr. Anjum Rashid. Today I will talk about acute poststreptococcal glomerulonephritis in children. It is a disease which is characterized by sudden appearance of edema, hematuria, hypertension, proteinuria, and variable degree of impaired renal functions. Now, it results from antecedent throat or skin infection by a nephrogenic strain of group A beta-hemolytic streptococci. Now, it is most common in children aged 2 to 12 years, with peak incidence at 5 to 6 years. It is rare before 2 years and after 18 years of age. Predominantly, males are affected, and the male to female ratio is 2:1. It is most frequent in tropics, and the high risk factors include overcrowding, poor hygienic condition, malnutrition, anemia, and intestinal parasite. It is estimated that about 472,000 cases per year occur worldwide, and among them 86% cases occur in children, and 97% of these cases occur in poor countries. Now, worldwide, it is proposed that 50% of the cases they may be subclinical, and asymptomatic symptomatic ratio is about 2:1. Thus, the actual incidence of this poststreptococcal glomerulonephritis is yet not known. Now, acute poststreptococcal glomerulonephritis is a pathological process which is characterized by inflammation and cellular proliferation of the glomerulus. This is mediated by an immunological process. Cellular and humoral immunity, they both play an important role in pathogenesis. Two mechanisms are proposed. First is the immune complex mediated mechanism, and second is the non-immune complex mediated mechanism. Now, in immune complex mediated mechanism, two important antigens of nephrogenic streptococci, they play an important role. First is the streptococcal pyrogenic exotoxin B, and second is the nephritis-associated plasmin receptor. Now, the first one is also known as nephritis strain associated protein, and the second NAPLR is a glycolytic enzyme, and it has glycerolaldehyde 3-phosphate dehydrogenase activity. Now, this is the normal structure and physiology of nephron, and the glomerulus is shown along with the detailed structure of the nephron. And in the last yellow picture, the 3 steps of urine formation is described. First is the filtration, second is the reabsorption, and third is the secretion. Now, friend, with the help of these diagrams, I will explain the immune complex mediated mechanism. As I have already mentioned that nephrogenic streptococci produce 2 important antigens. These are streptococcal pyrogenic exotoxin B and nephritis-associated plasmin receptor. Now, both these antigens, they activate the complement in the circulation and bind with specific anti-streptococcal antibodies and form circulating immune complexes. Now, at the same time, these antigens, they have particular affinity with specific sites in the normal glomeruli, and they bind there and act as fixed antigens. Now, these 2 antigens, they can activate the complement locally, which leads to generation of increased inflammatory mediators and recruitment of inflammatory cells. These cells include polymorphonuclear cells, monocytes, and T cells. So, there is local inflammation and endothelial cell and mesangial cell proliferation. Now, nephritis-associated plasmin receptor, it can also bind to glomerular basement membrane and mesangial matrix and trap and activate plasmin. This plasmin directly damages the glomerular basement membrane and also activate the procollagenases and matrix metalloproteinases. These 2 enzymes, they can also cause damage to the glomerular basement membrane. Now, the circulating immune complexes and the in situ immune complexes, along with the activated complements and some soluble protein, they readily pass through these damaged membrane and are located at the subepithelial area in the form of humps. So, the typical histological feature, which is the subepithelial humps, these are formed. Now, friends, the proliferation of the endothelial cells and the mesangial cell, they cause blockage of the renal glomerular capillaries, and this results in the decreased glomerular filtration rate, and this leads to oliguria and sodium and water retention along with hypervolemia, and this results in the clinical picture of edema, hypertension, and even heart failure, encephalopathy, and renal failure. Now, the inflammation and the glomerular basement membrane damage also leads to the leakage of blood ingredients, and this results in hematuria, proteinuria, especially the albuminuria, and RBC cast in the urine. Now here are three non-immune complex mediated mechanisms which have been proposed for the development of acute post-streptococcal glomerulonephritis. The first one is the delayed type hypersensitivity, which is mediated by helper or inducer T cell. This leads to infiltration of macrophages and polymorphonuclear cells, and also to the proliferation of resident endothelial cells and the mesangial cell. The second is the superantigens. These are the streptococcal M proteins and pyrogenic exotoxin. These lead to massive T cell activation, and there is release of interleukin 1 and interleukin 6. Now the third mechanism is the autoimmune phenomena. In this, an autologous immunoglobulin G is produced. This is a normal immunoglobulin which is modified by the Streptococcus neuraminidase. And now this autologous IgG, it acts as an antigen and elicit anti-immunoglobulin G rheumatoid factor and cryoglobulins formation. Now these cytokines and cryoglobulins and anti-immunoglobulin G rheumatoid factor, they all have been proposed a role in the pathogenesis of acute post-streptococcal glomerulonephritis. Now acute post-streptococcal nephritis is a representative disease of acute nephritic syndrome. However, the clinical picture varies and it ranges from asymptomatic microscopic hematuria to a very severe form, which is the rapidly progressive glomerulonephritis. Now, this can develop 1 to 2 weeks after an antecedent streptococcal pharyngitis, which usually occur in winter and spring, or 3 to 6 weeks after streptococcal pyoderma, which usually occur in summer season. Now, the typical presentation is the sudden onset of mild to moderate edema, gross hematuria, hypertension, significant proteinuria, and variable degree of impaired renal function. The classic triad of acute post-streptococcal glomerulonephritis is edema, hypertension, and hematuria. Now, the edema is usually mild to moderate and it appears abruptly. First, it involves the periorbital area, which is noted early in the morning, but however, it can become generalized. And the degree of edema depends upon the severity of glomerular involvement, the fluid intake, and the degree of hypoalbuminemia. Hematuria occur in 100% cases. It ranges from microscopic to gross hematuria. These gross hematuria occur in about 30 to 50% cases. Urine is smoky, cola or tea-colored or rusty, and this depends upon the amount of blood present and the pH of the urine. Now there is also oliguria, and the urine output is decreased below 180 ml per meter square per day. Now hypertension is present in 50 to 60% cases. It is usually mild to moderate and usually occur during acute phase in the first 1 to 2 weeks. Now it may become severe enough to cause hypertensive crisis like heart failure or encephalopathy. Now varying degree of proteinuria can be present, and however nephrotic syndrome is rare and is present in 2 to 4% cases. Now proteinuria may persist for several months. Now there are also some non-sign and symptoms such as malaise, lethargy, anorexia, fever, abdominal pain and headache. Now in the absence of hypertensive crisis, there is characteristic absence of arthralgia, arthritis, hepatic involvement or GI bleeding in acute post-streptococcal glomerulonephritis. Now I will discuss 3 important complications of post-streptococcal nephritis. First is the hypertensive encephalopathy. It can be the presenting feature and it occurs about 5% of the cases. There is high blood pressure, headache, nausea and vomiting, depressed sensorium, confusion, visual disturbance, aphasia, memory loss, papal edema, coma and convulsions. Now the second complication is the hypertensive heart failure and pulmonary edema. There is dyspnea, orthopnea and cough, systolic and diastolic hypertension, tachycardia, congested neck veins, cardiomegaly, pulmonary rales, hepatomegaly and increased generalized edema. Third complication is the acute renal failure in severe post-streptococcal nephritis and rapidly progressive glomerulonephritis. There is progressive oliguria to anuria, increasing edema, nausea, vomiting, drowsiness, convulsion, and persistent or worsening azotemia. Now friends, I will discuss the diagnosis of poststreptococcal glomerulonephritis. Now consider its possibility in children with symptoms which are secondary to hypertension and congestive cardiac failure, even in the absence of visible hematuria or a history of preceding streptococcal infection. Now in this case, if we find microscopic hematuria in urine analysis, this typically indicates acute poststreptococcal glomerulonephritis. Now the diagnosis is confirmed by finding the evidence of prior streptococcal infection, which is the streptococcal antibodies. These antibodies include anti-streptolysin O, anti-hyaluronidase, anti-streptokinase, anti-nicotinamide adenine dinucleotide, and anti-deoxyribonuclease B. Now, anti-streptolysin O, anti-hyaluronidase, anti-nicotinamide adenine dinucleotide, and anti-DNase B antibody, they are elevated specifically after a pharyngitis, and anti-hyaluronidase and anti-DNase B antibodies, they are elevated after pyoderma. Now, a streptozyme test is available which measures all the 5 streptococcal antibodies. However, whichever test is used, a rise in the titer of antibody measured at an interval of 2 to 3 weeks is required. Now, simply ASOT at 250 units or more is highly suggestive of a recent streptococcal infection. Now, second investigation is the complement profile. There is low serum complement 3 and CH50, and this is present in 90% of the cases, especially in the acute phase, and these return to normal within 6 to 8 weeks. Now, C1 and C4, they are normal, while C5 and properdin, they are usually low. Now, in the blood test, there is mild anemia, which may be normochronic and normocytic, and it is due to hemodilution. ESR may be raised. WBC count and platelet count, they are usually normal. However, rarely there is leukocytosis or thrombocytopenia. Now, hypoproteinemia and hyperlipidemia may be present, but it is rare, and the nephrotic picture is present only in 5% cases. Now, serum creatinine and blood urea nitrogen may be raised. Serum electrolytes, they are usually normal, and in the case of renal impairment, there may be hyperkalemia, hyperphosphatemia, and metabolic acidosis. And in the case of nephrotic syndrome, total serum calcium may be low. Now, on urine analysis, the urine output is decreased. It is concentrated and acidic. The specific gravity is more than 1.020 and the osmolality is greater than 700 milliosmol per kg. There is occasional glucosuria and proteinuria is common, which is more than 4 and less than 40 mg per meter square per hour. Now, in 2 to 5% of the children, massive proteinuria and nephrotic picture may be present. Hematuria can be gross or microscopic. RBC cast is present in 60 to 85% cases, and there are also dysmorphic RBCs. However, there may be some WBCs, renal epithelial cell, hyaline, and cellular cast in the acute phase of poststreptococcal nephritis. Now, in the imaging study, renal ultrasound shows bilateral normal to slightly enlarged kidneys with some increased echogenicity. The chest X-ray, especially in the increased circulatory volume, shows central venous congestion in the hilar pattern and enlarged cardiac shadow. And MRE brain in the case of hypertensive encephalopathy shows reversible posterior leukoencephalopathy in the parieto-occipital area. Now friends, kidney biopsy is usually not indicated in a typical case of poststreptococcal glomerulonephritis. However, these are some indications in which kidney biopsy should be done. First is the renal insufficiency, that is the low GFR less than 30 ml per minute per 1.73 meter square for more than 1 week. Second is the failure to document a recent streptococcal infection by rise in the ASOT titer or the streptozyme titer. Third is the normal complement level. Fourth is the nephrotic syndrome presentation. Fifth is the persistently low C3 beyond 6 to 8 weeks without resolution of features of acute glomerulonephritis. And the last one is the recurrent episodes of hematuria, especially the frank hematuria. Now grossly, the kidneys are symmetrically slightly enlarged and pale. They are dotted with small punctate hemorrhages on the cortical cut surface. On light microscopy, the glomeruli appear enlarged and are relatively bloodless. Diffuse hypercellularity of the capillary endothelial cell and the mesangial cell is present. There is also infiltration of glomerular tuft with the polymorphonuclear cells and the monocyte. In severe cases, epithelial crescents may be present. Now, the crescent in more than 50% glomeruli indicate rapidly progressive glomerulonephritis. Now, these are the light microscopic findings in a case of poststreptococcal nephritis. On the left side, you can see a normal glomerulus, while in the center, there is proliferative and inflammatory change. And on the right side, a crescent is visible around the glomerulus. And these crescents, they may be present in a typical case of poststreptococcal glomerulonephritis. Now, on immunofluorescence study, there are discrete granular deposits of immunoglobulin G and C3 on the glomerular basement membrane and in the mesangium. On electron microscopy, there are subepithelial humps which are the hallmark finding. These electron-dense deposits, they may be present on subendothelial and intramembranous locations. Now friends, I will discuss the treatment of poststreptococcal nephritis. First is the general measures. In this, bed rest is indicated during the early phase of the disease, especially the first week. And the caloric intake should be about 400 calories per meter square per day, and it should be in the form of carbohydrate and fats. Protein and salt intake, they should be decreased during oliguria, severe hypertension, and marked vascular congestion. Now, fruit juices should be avoided in order to limit the potassium intake. And the urine output should be measured daily, especially during the oliguric phase. Now, the total fluid intake should be equal to the output, which is the urine plus stool plus vomiting volume, and the insensible water loss. Now, specific measures include antibiotics. A 10-day course of systemic penicillin is recommended in order to limit the spread of nephrogenic organism. Now, in this, we can give benzyl penicillin 1.5 lakh units per kg per day intravenously for 4 to 6 days. Or we can give penicillin V or amoxicillin 50 mg per kg per orum 3 times daily, or even a single dose of intramuscular benzathine penicillin can be given. Now, the antibiotic therapy does not affect the natural history of glomerulonephritis. Now, for hypertension, sodium restriction is required, and diuresis can be achieved with IV furosemide 1 to 2 mg per kg per dose. Other drugs which can be used in hypertension are calcium channel antagonists such as nifedipine, vasodilators such as hydralazine, and AC inhibitor like captopril, enalapril, and lisinopril. Now, in most cases, edema subsides spontaneously at the end of first week and with the onset of diuresis. However, fluid and salt intake, they should be decreased during the first week. Now, in most severe cases, a negative fluid balance is required, and even diuretics such as furosemide, they can be used for the control of edema. Now friends, I will discuss the treatment of complications of poststreptococcal nephritis. First is the hypertensive crisis. In this, certain drugs are recommended in the emergency situations like labetalol, diazoxide, sodium nitroprusside, hydralazine, sublingual nifedipine, and even methyl-dopa can be given. Now, in less urgent situation, hydralazine in combination with reserpine, they can be given intramuscularly, and it can be repeated within 2 to 3 hours. Now, if hypertension persists, methyl-dopa in a dose of 20 to 40 mg per kg per day can be given. And furosemide is added for concomitant hypertension and circulatory overload. Now, anuria and oliguria occur in 3 to 6% of cases. In this case, hospitalize the child, and protein should be restricted to less than 0.5 gram per kg per day. Now, only high quality protein can be given like chicken and eggs. Fluid restriction should be done, and the fluids can be given in the form of 10-20% dextrose water. And the volume is equal to insensible water loss, which is 400 ml per meter square per day in a child, plus the output, which comprise the urine, stool, and vomiting volumes. Now, protein restriction is also required, and avoid fruit juices. However, if there is hyperkalemia, it should be treated as in the acute renal failure. Now, sodium bicarbonate is recommended for metabolic acidosis, and if there are seizures, then diazepam can be given. Now, in the case of hypertensive heart failure, Advise bed rest, proper position, give moist oxygen, restrict sodium and fluid intake, and also digitalize the child. Give diuretics furosemide 1 to 2 mg per kg per day, and also give antihypertensive to control blood pressure. Now friends, I will discuss the prognosis of acute poststreptococcal glomerulonephritis. Now complete recovery occur in more than 95% of children. However, in a few cases, initial injury is so severe that persistent or progressive renal failure can occur. However, in most of the patients, the histological regression of the disease can occur and ultimate prognosis is good. Now, only 5% cases lead to rapidly progressive glomerulonephritis, and in less than 2% of the children, chronic kidney disease can occur. Now, edema usually resolves within 5 to 10 days, and the blood pressure returns to normal after 2 to 3 weeks. However, persistence of elevated blood pressure for as many as 6 weeks is compatible with complete resolution. Now, gross hematuria usually disappear within 1 to 3 weeks, but it may be exacerbated by a physical activity. Now, C3 concentration returns to normal in more than 95% of the patient by the end of 8 to 10 weeks. Now, microscopic hematuria usually disappear after 6 months, but the presence for as long as 1 to 2 years should not cause undue concern, as complete resolution of the renal disease can occur. Now, proteinuria, it may disappear within the first 2 to 3 months, or it may slowly disappear over a period of 6 months. However, intermittent or postural proteinuria has been noted for 1 to 2 years after the onset. Now, consider the possibility of chronic renal disease when both the hematuria and proteinuria, they persist longer than 12 months. Now, clinical manifestation of the disease rarely occur after the first 3 months, and the second episode of the glomerulonephritis is rare. In the end, I will discuss the follow-up and long-term monitoring of poststreptococcal glomerulonephritis. Now, explain the nature of the disease, its course, and the eventual prognosis. Ensure compliance with the follow-up program. Blood pressure and urine examination for protein and blood should be done in each follow-up. Now, a follow-up at 4 to 6 week interval for the first 6 months and at 3 to 6 month interval thereafter, until both hematuria and proteinuria have been absent and blood pressure has been normal for 1 year. Also document that C3 has returned to normal after 8 to 10 weeks. Thanks for watching this video. Please like, share and subscribe to my channel. Thanks.